Good evening everyone. Topic for my presentation is modifying sclerocorneal tunnel construction in manual small incision cataract surgery, crescent versus keratome. Introduction. The progress in cataract surgery aims to discover surgical techniques capable of delivering accurate and predictable outcomes. Manual small incision cataract surgery is regarded as a safe, straightforward, reliable and economically viable method for cataract extraction. The lower expenses associated with instrumentations make manual SICS particularly advantageous. A well-constructed scleral tunnel promotes self-sealing, enhances wound stability, consequently reducing surgically induced astigmatism. Proper tunnel construction is necessary, for which availability of instrumentation is necessary, which is sometimes difficult in resource-limited peripheral institutions. So the aims and objectives are to study the difference of surgically induced astigmatism between sclerocorneal tunnels made with crescent versus keratome, to see for the complications associated with use of keratome for tunnel construction, and to validate the use of keratome for tunnel construction in the resource limited institution. Materials and methods. This study was carried out at a tertiary care hospital from June to November in 2023. In this investigation, 60 patients were selected and they were categorized into two groups. First group consisted of 30 individuals who underwent the SICS surgery with sclerocorneal tunnel construction using crescent, and the second group consisted of 30 patients who underwent SICS surgery with sclerocorneal tunnel construction using keratome. Before beginning the study, all study participants were provided with written and informed consent. Inclusion criteria: patients experiencing vision impairment due to cataracts of any severity. Exclusion criteria: patients with concurrent visual conditions such as glaucoma or corneal abnormalities which could impact post-surgical visual results, and the patients with traumatic and subluxated cataract. Pre-operative assessments were done, which included visual acuity, Snellen's visual acuity chart, slit lamp examination for cataract grading, intraocular tension, fundus examination, pre-op keratometric reading, A scan, B scan in hazy media, and post-operative keratometry and refraction were done 1 month post-surgery. These are the images showing tunnel construction using 2.8 mm keratome. Result. The mean keratometric readings in the first group before surgery were K1 43.97 and K2 44.56, while after surgery they were K1 44.37 and K2 was found to be 44.95. In the second group, the pre-op mean keratometric readings were K1 44.12 and K2 was found to be 44.76, which changed to K1 44.55 and K2 45.12 post-operatively. The mean astigmatism at 1 month post-op was found to be 0.7 plus minus 0.3 in the first group and 0.9 plus minus 0.4 in the second group. There was no statistically significant difference in both of the groups. This is the table showing surgically induced astigmatism in both of the groups. This is the table showing mean surgically induced astigmatism in both groups. It was found to be 0.9 in the first group and 0.7 in the second group, which was found to be statistically insignificant. Discussion. This was the comparative study in which we examined the surgically induced astigmatism in both of the groups. Till date, there has been no previous research on the comparison of effectiveness of blades, including crescent and keratome in cataract surgery. Mean astigmatism in both of the groups was found to be statistically insignificant. Thus concluding, sclerocorneal tunnel with crescent and keratome produces similar astigmatic outcome, and there were no complications experienced by the surgeon during tunnel construction by keratome. Thus this study suggests the use of keratome for tunnel construction resource limited institution, provided surgeries are performed by experienced hands. Thank you.
Age criteria?
Yes, sir.
Age criteria was taken. Any inclusion on the age, exclusion on the?
No, sir.
So you said that it is basically resource limited. So how does it make the difference? The crescent is around 30 rupees or the keratome is also 30 rupees?
But we are doing surgery in only one instrument. Means incision was also taken with the keratome only, and tunnel was made with the keratome, and side port was also done with the keratome.
Right. Thank you.
Thank you, sir.